Of enhancing clinical practice and outcome stream at the SNOMED CT Expo 2025. Thank you to FAST for sponsoring the stream. My name is Sonja Ulrich, and I'm the Software Development Manager at SNOMED International, and I'll be your moderator for today's session. We'll address all questions at the end of the presentation. For our online audience, please use the Q&A button to submit your questions to the presenter. And for those attending in person, feel free to use the microphone here provided in the room when the time comes. It's now my pleasure to introduce Yasmine Bouyakoub from Clinique Universitaire Saint-Luc, who will be presenting from free text to 100% structured data, how to improve compliance of end users and adapt SNOMED CT to clinical practice, experiences of an academic hospital. Yasmine, over to you.
Thank you for the introduction, and good morning, everyone. My name is Yasmine Bouyakoub, and I'm a terminologist at Clinique Universitaire Saint-Luc. It's my pleasure today to be here to share with you the work of our terminology team on the topic how to improve compliance of end users and adapt SNOMED CT to clinical practice. Before diving in, I would like to give you an overview of this presentation. First, I will provide you some context about Clinique Universitaire Saint-Luc and the use of SNOMED CT in Belgium. Then we will explore the key points. It's too small. We will then explore the key points of our hospital transition from free text to fully structured data. Then we will focus on the main topic of this presentation, around 4 key areas based on our experience. And then we will discuss challenges we face, which can be summarized in 3 words: maintenance, relevance, and resistance. Clinique Universitaire Saint-Luc are located in Brussels, in Belgium. It's a French-speaking academic hospital associated with UC Louvain University. It has around 1,000 of beds, and it's one of the largest hospitals in Belgium. The strategic plan of Saint-Luc serves as the foundation for our hospital transformation. It's composed of 3 major parts. The first one, optimization. It's implementing initiatives that help Saint-Luc strive for excellence in many key areas like patient partnership and staff engagement. Next, the hospital reconstruction. And lastly, the modernization of the IT infrastructure. Indeed, Saint-Luc has introduced a modern neo-electronic health record. Now let's take a look at how SNOMED CT is used in Belgium. Belgium is member of SNOMED International since 2013. Since November 2024, we have had a Belgian edition of SNOMED CT, which is updated monthly. It includes translation in all of the 3 official languages of Belgium: Dutch, French, and German, but mainly in French and Dutch. Belgium has selected SNOMED CT as the recommended clinical reference terminology for clinical information systems. And as you know, SNOMED CT is an essential part of the digital health infrastructure. Considering all this information, SNOMED CT was chosen as the main terminology for the new EHR at Saint-Luc. Now let's take a look at how our transition from free text to fully structured data went. Before this new system, we used a homemade EHR, which was connected to over 400 applications for labs, appointment scheduling, etc. It was mostly free text, very little structured data. But one night, everything changed. After 8 years, after 8 years of preparation, we went live on the night of 28 November 2020. We went live with a new EHR, that's Epic. Epic is a very famous EHR, very used in the USA and other parts of the world. Now, our data are centralized. We have a major reduction of free text. It's mostly used only in notes, and we have much more structured data. 2 points I would like to highlight is that we were the first hospital in Belgium, but also in the entire French-speaking world to adopt Epic. Now, how is SNOMED CT used in our new EHR? SNOMED CT plays a crucial position in this new EHR. We mainly use 5 hierarchies. The 3 first hierarchies are used for anything diagnosis related. That's the problem list, medical history, and family history. The procedure hierarchy is used for surgical history and substance for non-drug allergens. An important point I would like to highlight is that in our EHR, SNOMED CT is not just used as the mapping, but it's actually the core of the database itself. For example, all diagnosis and surgical histories entries are SNOMED CT concepts. The only exceptions are custom local concepts that don't yet exist as pre-coordinated SNOMED CT concepts. And we also use SNOMED as a mapping for bacteria and vaccines. So as we have seen, user transitioned from this to that. This represented a significant disruption of their clinical practice. Essential part of the patient record, like problem list, could no longer be entered as free text, but the user has to select a term from a list of sometimes unfamiliar terms. So how can we improve user compliance and adapt SNOMED to their practice? From our experience, we identified 4 key areas we would like to share with you today. The 4 keys are communication between end users and terminology team, data quality, data relevance, and the importance of structured data. The rest of this presentation will be structured around these 4 key points. Let's start with the first key point, communication between end users and terminology team. One of the first things we implemented was education on SNOMED CT for the users. When the hospital welcomes new doctors or residents, they receive training on how to use Epic, and they also have access to a podcast we recorded that explains the basics of SNOMED CT. We also provide on-demand training session by department in small groups. This session typically lasts about an hour, during which we cover the basics of SNOMED CT, how and why to use it, and answer any questions. These sessions are very valuable because they allow us to collect feedback and to get a real sense of what's happening on the ground. And for the users, they can understand the benefits of using structured data. Another point, it's sometimes these sessions are not enough to motivate users to use structured data, so we have to reach out directly to doctors and specifically the department head, and we suggest to review the available content SNOMED CT. So as we will see later, it is possible to select favorite SNOMED CT concept specific to our department and put it on a list that is specific for the department. So we review this list together in order to optimize it. Sometimes the doctors are in middle of a consultation, they are looking for a diagnosis and they can't find it. At that point, they would need to create a ticket on the support platform or send us an email. This isn't always easy, and our terminology team miss opportunity to improve the list of terms. To simplify this process, we have set up terminology help button directly within Epic, so the user can more easily contact us and reporting us missing concept, suggest translation, synonyms, and so on. And we also have an on-site training team that is very close to the users. They are responsible for the Epic training and also to provide on-site support for the users. They collect very relevant feedbacks and then transfer it to the terminology team. Next key point, the data quality. One of the biggest projects we are working on is the French translation of the Belgian edition of SNOMED CT. In 2020, so at the moment of the go live, there were 50,000 of active concepts had at least one French description, and over 60,000 there were more than 60,000 active French descriptions. But since 2022, the terminology team has been responsible for the French translation of the Belgian edition of SNOMED CT. And thanks to this work, we have now more than 200,000 active concepts with at least one French description and more than 300,000 active French description. This means since the go live, we have added more than 300,000 of French description in our system. If you would like to have more information about our translation journey, you can check out the poster of my colleague Kim. Another point for data quality is to improve the database with synonyms, abbreviations, and acronyms. These additions make the search for a term more easy because you can search for the same concept but using different words. To add these synonyms, abbreviations, and acronyms, we can analyze comments left by doctors on diagnosis or surgical histories. We can extract these free text comments and analyze them, for example, by applying an n-gram analysis. So with this, we can identify the most frequent sequences of 1 or 2, 4 consecutive words. We can also receive directly feedbacks from doctors requesting to add synonyms, abbreviations, and acronyms. In 2025, we have added more than 5,000 of synonyms for diagnosis and surgical histories. And last point for data quality is to add concepts that are missing in SNOMED CT. It's the same that for synonyms, we can analyze comments left by doctors who received directly feedbacks from doctors. And for currently, we have more than 3,000 of local concepts. So it's concepts that are not existing yet in SNOMED CT. Third key point, data relevance. By developing preference lists, currently, we have more than 100,000 of diagnoses available for entry and more than 50,000 of surgical histories. These numbers are quite large, which can make the search of a term difficult. To simplify this, we've developed preference lists based on usage frequencies and after physician's validation. This list is a list of commonly used terms grouped by specialty. And when we make a search, it will first search in the preference list, and if there is no match, then it will search in the entire database. There is two types of preference lists at hospital level and at department level. At hospital level, it's the list available for all users, and the terms are grouped by specialty. There is one list for diagnosis and one list for surgical history. And for the department level, it's a list specific to the department, and it's only accessible to this department. And we review this list with the department head. Here is an example of the preference list at the hospital level. So it's the list that is used by all the users. On the left, you can see all the different specialties, and the user can either select a specialty and then click on all the terms they need, or they can use the search bar on the top to search for a specific diagnosis. Last key point, the importance of structured data. One of the most effective ways to motivate users to structure the data is to show them the real benefits it can bring. For example, reporting. If you have complete and well-structured data, you can easily report. For example, I can quickly generate a chart showing all my patients seen in 2024 with heart failure broken down by sex and age. No need to list all types of heart failure, just use ref sets based on SNOMED CT hierarchies, and it will automatically add all the types of heart failure. You can easily share the results with your colleagues or get more details about the patient, like current medication, labs, etc. And you can also export to Excel. Another point is automatization. Structured data enables the automation of certain workflows. For example, you can suggest a certain cancer staging form based on the cancer diagnosis that added in the problem list. In this example, we added vaginal carcinoma in the problem list, and then the form vagina UICC 8 edition was suggested automatically, and I can easily complete it. Another tool that physicians appreciate a lot is the synopsis. The synopsis brings together relevant information about a specific condition. This information could be specific medication, labs, procedure, scores, and more that are relevant to a specific condition. But to be displayed in the synopsis, it has to be structured. And this is a major motivation for the doctors to structure their data. And you can track easily this data over time. Here is an example of synopsis for multiple sclerosis. And you can see on the left specific medication, labs values, procedure, and scores that you can easily track over time. And lastly, of course, structured data is the foundation of interoperability. As you know, it's the base to exchange data with external sources. Here are some examples, like the BEER, the Belgian Integrated Health Record, and on international level, there's the OMA project, but of course, there is also the e-health data space and other projects that when you have to structure your data to exchange your data. Now, I would like to share with you the challenges we are currently facing. The first one is maintenance. To manage inactive and new concepts, we have currently 4 updates per year in our EHR, 2 for SNOMED CT International and 2 for SNOMED CT Belgium, and it's carried out by our terminology team, and it takes a lot of time to do it. When there is an inactivation of concept, we have to analyze where these inactive concepts were used and find a replacement if relevant. And for the new concept, we have to check if they overlap with the local concept we may have created previously. The relevance sometimes is really difficult to find in SNOMED CT the concepts that were needed by the doctors, especially in the procedure hierarchies. Currently, we have more than 1,000 of local concepts for surgical history. So these are concepts that are not existing yet in SNOMED CT. But when we review the content by department, this number quickly increases. By example, in the urology department, after reviewing, 50% of the surgical history available for that department were local concepts. So that was a concept that was not existing in SNOMED CT. So when we will reviewing other departments, the number of local concepts will likely increase. And finally, the last challenge is resistance. Even if we are in a fully structured system, users still manage to find a solution to use free text. For example, diagnosis, they select the diagnosis and then they change the display name. And this can be really dangerous because it changed the meaning of the concept. And the underlying SNOMED CT ID doesn't change, so the system can have an incorrect behavior. At the beginning, when free French translations were available, many of these changes had a different meaning from the original one, but now that we have added more translations and synonyms, it's much better used, and these examples are less frequent. And for the surgical history, they found another workaround. They used the general concept surgical procedure, and then they put the actual procedure in the comment as free text, even if this procedure exists in the database. We have reporting tools to analyze and track this kind of behaviors, and we are working to aware users on the consequences of such behaviors. For the perspectives, we would like to continue our work and to improve our collaboration with department heads to providing more education, content revision, and project where structured data plays a key role. And we would like also to improve our SNOMED CT update process, and would like to automate some steps to gain to spare some time. Voilà. That brings us to the end of this presentation. Thank you for your attention. I hope this give you a good insight into our work as a terminology team in a hospital. Feel free to ask any question or to discuss further. Thank you.
Thank you very much, Yasmine. That was a very interesting presentation. I already have a few questions just online, so I'll start with those. Margaret Jäger is asking, how often do you offer the training, like once when they start their job or once a year?
When there are new doctors, they receive the podcast, so they have to watch it. And for the on-demand training session by department, it's the department that are asking us to provide this session, or we can also contact the department and say we would like to have more information about SNOMED CT. So there is no it's not I don't have a number to say how many times we do it in a year.
Thank you. And she also asked about nursing information. Do only doctors use the system?
No, also the nursing, it's limited. It's not like the doctors, but it's mainly the doctors.
And the last question was, can the clinician see the synonyms when they look up the diagnosis in EPIC?
When they do a search, it will, in the list of results, it will be the official name and after there will be the synonyms. So they can see the synonym when they are making a search.
And there's another question about what a protein-oriented synopsis is, if you could explain that.
What is
A protein-oriented synopsis?
protein?
Problem-oriented synopsis. I was
what is the synopsis I've shown. It's problem oriented because it's specific to a condition. Like for the multiple sclerosis, it's problem oriented because it's oriented to the multiple sclerosis. It's the same.
Okay, I think that answers the questions that we had online. Please.
Hi, I'm Christoph Fearens from Vitas in Sydney Glass. I was wondering, how do you get your clinicians to use the full potential of SNOMED, meaning the granularity? Because you can give in heart failure or a procedure, general procedure. Of course, if you want to be using it for like rare diseases, you need to go very, very deep. Is there any action that you have taken to try and get clinicians to get to that level of detail?
Sometimes when we show the tools like the reporting and the synopsis by himself, he can say it will be more relevant to add granularity, but we don't really have a strategy to say which granularity you have to use. So no, not really.
What are your experiences? Are
So
limited or is it very variable?
It's very variable. It depends of the department head. When the department head use really well the system, then all the department will use really well the system. But if the department head are not convinced by structured data, then all the department will not be convinced.
Thank you. And I have another question. It's about maintenance of the problem list, because you can add, but is it also possible to take out?
By the doctors?
Yes, or to close off to say
Yes.
this pneumonia is finished
Yes,
now?
of course, in our hospital, the rule is that in the problem list, you only put active problems. So when it's not active, you can resolve the problem, you can add it to the medical history, but this is the rule. So there is buttons to say it's resolved, you can remove, you can add it, switch it to medical history.
And how is the adherence to that? Because one of the dangers is that people are just saying, I don't care.
It depends of the department head.
Okay, thank you.
Are there any other questions? Yes, Stefan, please.
How is context represented? Family history, suspected diagnosis, planned procedures, provenance of information. Is this more or less implicitly contained in the many forms you use?
For family,
Are you using an information model such as FIRE, OpenHR?
I'm not sure if I've understood well the question, but for the family history, there is a specific section for family history. So it's not in the problem list. It's
Okay, that means you have a form, and in this form there is a entry field for.
yes, you can put my mother has cancer, my father has this. It's really specific. It's not in a problem list. So you,
Okay, but it depends on, let's say, the implicit semantics of the form, and it's not really interoperable.
no, it's a specific section in Epic. So in
Yeah, so
Epic,
it depends on Epic. It's not
Yes, it's in
independent
Epic.
of. Yeah, this is what I want to know. Thank you.
okay.
Any other questions?
Thank you so much for a very interesting presentation. Really good. So all these local concepts, are you trying to promote them to like the Belgium extension or the international extension?
It depends. When it's procedure at the beginning, we try to do this, but when we have to do this, we have to add reference from literature to say yes, it's used, and this is not possible. I just tried 3 times, and it's too difficult to always find literature that say yes, it's something used. So for the procedure, no, we just stay in the local concept. But for synonyms, for the diagnosis, then we try to add it in the Belgium edition of SNOMED
Okay.
CT.
I see. And what's your opinion on this? What do you think?
I think it's strange for the procedure hierarchy because sometimes the doctors see concept on SNOMED CT and say, what's this concept? I never heard of this. So maybe sometimes I have the feeling that procedure hierarchy, there is concepts that are specific to United States or America, and in Belgium, nobody knows of this concept. So there is this and other concepts that are very frequent in our hospital that are not in SNOMED CT. So it's strange how procedure hierarchy is built, but yes, it would be very nice to have all our procedures in the Belgian edition and then the international edition. But for the moment, we cannot do this.
We've made a local workaround. Thank you.
I think we have time for one last question.
Thanks for your presentation, really interesting. I wondered, how do you store these local concepts? Are they post-coordinated, and do you store the expressions as well?
It's we map the local concept with one or more similar SNOMED CT concepts. So we just look in SNOMED CT concept and search for the concepts that are similar. So the local concept is connected to SNOMED CT.
Okay, well, thank you.
Hey, thank you very much. That concludes this block of sessions. Thanks again, Yasmine, for your wonderful presentation. To our online delegates, the next group session will begin at 11:30 UTC. You can rejoin via the event lobby. And to our on-site delegates, lunch is being served in the exhibition hall, and concurrent sessions will resume at 1:30 local time. And this is your last chance for the passport game.